that is what blew my mind, that this conversation just doesn't happen unless you hit menopause or perimenopause. So we kind of spend, women, most of our lives, unless we're pregnant, not really understanding our hormone levels at all. And it is a really confusing landscape. When I've spoken about it since on my Instagram, this is probably the first time I'm speaking publicly about it at all. After our conversation, I spoke to you and I said, I really suffer with anxiety just before my period. I really suffer with heavy periods. I have burst cysts, but for my entire life, I was put on the progesterone only pill. And I felt great. But then I started to not feel great again, and I came off, and then I just didn't know where to turn. And you mentioned, come and see me, maybe you might be hormone deficient. Had never entered my brain, ever. And I think that's the really interesting thing. We might think about going on a pill, like the conventional treatment to stop fertility, but we don't think about it in terms of how we feel. And then we might think about HRT when we reach menopause, but then everything in between, we just kind of struggle with. So when I came to you, it was very symptomatic. It was very like talking about how I feel. We did do a round of bloods just to check for any nutritional deficiencies, which I think was really, really helpful. And again, anyone listening to this thinking, wow, somebody in their 30s or somebody like Louise's daughter, 21 or 20, taking hormone treatment might feel a bit uncomfortable about it, might feel quite shocked about it. So I really want to lay the groundwork here and say, do we have a need to be frightened about this? Or is this totally safe for somebody in their 20s and their 30s to take with the symptoms that they're experiencing? Because I think that's probably the biggest fear for most people. And I can say personally, which is totally anecdotal, I've never felt better since taking this, and I had very low progesterone. And I only need it for a few days before my period, and it's really calmed me. My periods aren't heavy anymore. And I've never really spoken about myself like this on the show because it's not about me. But I do think it's really important to voice this for any women who are experiencing these symptoms and just think they just need to suffer because it's not fair.
Absolutely.
And so the stigma of me even taking that first pill, I have to say I was terrified. And then I felt great. And I was like, oh, I don't ever want to stop taking this. And so I think I really want to get into the stigma around taking this if you're not perimenopausal, because a lot of people will fight out that argument.
Yeah, and I think the thing is, there's lots to unpick there, but I think the thing is, when we give hormones, it's often called HRT. And if you Google HRT, it will say risk of breast cancer. And then everyone's like, oh my goodness, but I'm not menopausal. And oh my goodness. And that stemmed, we spoke about it in the last podcast, of evidence from 20 plus years ago using synthetic, so chemically altered hormones that do have risks, but this risk of breast cancer wasn't statistically significant anyway. But we don't prescribe that now. We just prescribe the same natural hormones. So people aren't scared taking the contraceptive pill, but it's synthetic. But they're suddenly scared when it's hormones because of this connotation, this hangover effect from this WHI study from years ago, thinking about HRT. But we're very simplistic when we prescribe hormones now because we can prescribe the hormones separately. And you've just said you're taking some progesterone. And you might be that if progesterone didn't work for you, we would then consider estrogen, and you might need some estrogen added in. And actually, the beauty of starting when someone's got PMS and PMDD, we often can start very low dose and we can just try, and then you sort of segue into having maybe a bit more as your own hormones decline. So in an ideal world, you will never experience perimenopause and certainly never experience menopause because you're just topping up what's missing, if you see what I mean. It's like if someone, I don't know, I'm just thinking how else to describe, if someone had raised blood pressure, for example, we treat it because we want to reduce future risk of a heart attack. Raised blood pressure doesn't usually cause problems. If it's very high blood pressure, it can cause headaches and people feeling quite tired, can sometimes affect vision. But we wouldn't leave someone for their blood pressure to be as high until it causes symptoms. That would be nonsensical. And it's a bit like this, because there's been so much misinformation about hormones, we have sort of ignored it, and women have then been, I see women in my clinic who are really struggling, they've given up their job, their partner's left them, they've got so many symptoms, their quality of life is dreadful. But actually, we shouldn't be waiting for that long. And the problem is also, I see women who are perimenopausal and menopausal, but they've got a history of PMS and PMDD. And then when they have the right dose and type of hormones, they say, wow, I wish I'd taken or started this 10, 20 years ago. So that's where this awareness is really important. And a lot of people with a history of PMS and PMDD then become pregnant and they go, wow, this is incredible because you've got good levels of hormones in your body. And that, for anyone listening, is a really important sort of telltale sign that actually if you do feel so much better when you're pregnant, obviously there's lots of reasons why you can feel better when you're pregnant, but it is a soft sign that actually maybe you do respond adversely to hormones if you feel a lot worse when you don't have them at certain times of the cycle. But hormones like estrogen, progesterone, testosterone, when we prescribe them, they're very short acting. They only last the day that you use them, so they don't build up in the body. If they don't work or someone has an adverse effect or a side effect, then you can stop it and they'll come out of your system. I spoke to someone today who's got lupus. She's had lots of problems. She's had some antibiotics. She's had some other medication for her lupus. She'd started HRT. She'd had these blisters and mouth ulcers, and she didn't know what was going on. And I don't know how much is related to her hormones. So she's just stopped everything. And then she's going to introduce very gradually one hormone at a time and see, because it probably wasn't related to her hormones. It's probably related to some the antibiotics she had. But you never know in medicine, and it's always better to do things gradually and patients being in control. And I think that is the beauty, if someone has an implant, for example, once it's in, it will last for a few months or a few weeks, depending on the type. And then you can't take it out. If you have the Depo Provera injection of progesterone, that's it, it's in for 12 weeks. This is very different. Even a tablet, it gets metabolized in different ways. We're very lucky that we can just give these hormones safely and try. And if it doesn't work, then you haven't lost anything, But if it improves, like you've had such an amazing response with very simple progesterone, and having the natural progesterone, Utrogestan in the UK, is a lot safer than having, the mini pill that you had when you were younger because it's synthetic. So, we've got to stop this fear. And I think you often get scared of something when you don't understand. And that's what's happened. We haven't been given the information. And if you don't have the information or you have wrong information about what hormones are, then the first thing you do is get scared. And that's where information and education is so important.
I think it's one of these things where people are listening, and I feel very lucky that my job, I managed to meet you and then come and see you for a consultation a few weeks later, as I've got to book in for an appointment. But for anyone who's listening to this and they couldn't come and see you, they just didn't have the access to you, such as the financial access, or they lived in a different country or whatever that was, they don't have, and also you only have a limited amount of spots, can't see everyone who's got PMS or PMDD. What would the reaction be going to see a GP and asking for this? Like, I want to make that kind of statement because I'm thinking,
no, you're really,
it's
really important. And one of the reasons, we develop Balance app is so people can have free information. We update the information all the time so they can really feel empowered wherever they live and whoever they want to access. The problem is medical healthcare education hasn't caught up, and we have developed a Confidence in Menopause course which people can log on to. It's really designed for healthcare professionals, but it's not just menopause, so there's sections about perimenopause but also PMS and PMDD, so really important that people have this knowledge as healthcare professionals. We've also produced some sort of treatment guidelines that healthcare professionals can contact us and we can share that what we do in our clinic. And medicine is a science and an art, and the art is individualizing care and listening to patients. And over the last 8 years of dedicating my work just to hormones, I've learned so much. But there's also work that's been done in the past that has been ignored. So many women now who have PMS, PMDD have heard of someone called Dr. Catriona Dalton, who sadly now died, but she's written some great books about PMS and PMDD, and she writes very clearly about the effects of progesterone and how beneficial they were. And she like we do sometimes use progesterone vaginally, because then you can get higher levels in the body and it's the pure progesterone, and it can be transformational for some women. But she wasn't believed and she had a really difficult time. The establishment went against her, and then no one sort of continued her work after she died, and we've sort of reactivated because she was years ahead of her time, like a lot of pioneers are, I suppose. And no one really, it's different now, because when she was doing it in the 60s, 70s, 80s, we didn't have social media, we didn't have the internet. But in fact, even now, actually, one of my doctors who works with me emailed me today and said, Louise, this amazing lady I met had really severe postnatal depression. The psychiatrist wanted to give her ECD and antipsychotics, and she got hold of Catriona Dalton, and she was given Cyclogest, Pessaries, and she was amazing, and she felt so much better. And then her next pregnancy, she was given some Cyclogest, and she just wants to come and record a podcast with me, which is wonderful. But so people then found this doctor out, and people do, women have a way of connecting, as you know, but it's easier now. But what isn't easier is that sometimes healthcare professionals aren't catching up, or they're scared because they haven't been taught. But I think, the good doctors have some professional curiosity. If I have a patient asking me something, then I would always challenge myself and think, well, why are they asking that? Where have they got that information from? Could it make sense? And sometimes, people might come and be asking for some obscure tablet that they've seen on the Mail on Sunday health section that's been trialled on 3 mice or something. And of course, that wouldn't be rational to worry about that. But actually, if we're talking about natural hormones, which are biologically active, I've spent hours poring over basic physiology and texts, and just looking at how our hormones work naturally in our body. Because if we know how something works when we're healthy and we don't have it, then it's easier to understand how important it is and how safe it is to replace it.
Mm-hmm. So do you think a GP now would be more considered to prescribe progesterone or estrogen?
I hope
testosterone?
So. I mean, it is in
I want to give the listeners.
No, it is in some of the guidelines, and I'm hesitating because, I see a sort of skew population, because in our clinic we see women from all socio-economic backgrounds, from all ethnicities, who come because the NHS has failed them. They don't come because they really want to see us. They come because they want help. So we don't see the people who are having a great experience, doing really well, everything else. So, when I go to conferences in the UK and abroad, a lot of people say, gosh, Louise, your Confidence in the Menopause course has transformed the way I think. So thank you so much. So there is this effect that's happening. So it's always worth asking at your practice, is there someone who's got a specific interest in female hormones? Is there someone, nurse, doctor, pharmacist, who might be able to help me, to give me some individualised advice? Or is there someone in another practice? Maybe I have to change practice. Or is there a specialist in the hospital? You're allowed as a patient to have second opinions. That's the other thing. I get quite nervous going to see my doctor because I think they're so busy, they're running late, they don't really need to see me, there's more sick people. And then if they say something, you sort of go, oh yes, okay, that's fine. But actually, you are allowed to have, and even as doctors, we don't all agree. It doesn't matter if we don't all agree, it's because there isn't really solid science. But we haven't got solid science that supports us. We don't have the evidence, because who's looked and done proper studies in women with PMS? No one.
Thank you so much for listening to the show. The link to the full episode is in the description.